AATS Mitral Conclave 2015. We're actually in a break right now, but a lot of energy this morning, and you can hear them trying to call people back into the meeting. But this is a unique opportunity for me to visit with two of the world's experts in rheumatic heart disease. Thrilled to be joined by Dr. Taweesak from Thailand. I know you've had extensive experience, and Dr. Manuel Antunes from Portugal. Manuel, tremendous experience in South Africa and Mozambique and all that. You know, it's interesting. When I was in medical school, we actually saw rheumatic heart disease in the United States. Now we don't see much. But so what's the burden of rheumatic heart disease in the world? What's your experience?
Well, all the southern hemisphere, and that is South American, Southern
different disease. It was my understanding. I mean, not a different disease, but a different pathology of the valve in Bangkok. I mean, in Thailand and in Asia.
Yeah, that's a very interesting question. Recently, I traveled quite a lot to several countries, and although the disease is rheumatic in the same pattern, I mean, inflammation, thickening, but there are some various degree of difference. The calcification, the thickness, the toughness of the tissue from country to country. There are some difference. They're very interesting. We should learn something from that.
That's it.
Yeah.
So what important is when you read the literature, you have to clearly separate the reports that come, for example, ventilation to other forms of therapy.
I know I've heard you talk many times about this question. When do you repair? When do you replace? And obviously, what Manuel.
May I say that he is an expert of making repairs that are impossible to repair.
I've seen I agree. I've seen it. But so the question comes up, and I think what Manuel was alluding to is this thing about follow-up of the patient, anticoagulation, and durability. When do you repair? And when I know you're an expert, and when do you replace?
Yeah, I think that's one of the very questions, because there are several factors being involved: the patient factor, surgeon factor, socio-economic factor. So I think we just try to find the better way, like in South Asia and Thailand, to replace the valve in young and female living rural area. Although they offer the immediate good result, but there's some problem. So we try to repair, and then try to repair with the techniques that we learned from the pioneer, like Professor Antunes is a pioneer in this, and then try to develop something that at least can postpone or improve the quality of life of something like the young lady who would like to have a baby. They can have baby, and then they come back later. But overall, through the year, we know that we have the better technique because we understand the disease more. And the other thing is that for whatever reason, if the repair fails, the patient have time to come back. Instead of mechanical valve, that is
mortality is very involved repair.
Yeah, that is a key that we try to do.
Exactly right. Right. A failed prosthetic valve can be catastrophic.
And
we can develop quickly.
And the good news is that with this kind of approach, we slowly move toward more complex, like mixed lesion MS, MR, or predominant MS. We can repair more and more with, at least right now, very gratifying midterm result and continuing.
Well, it's different, but I'll come back to that in a second. But you've shown us techniques where you're actually almost taking off layers of the inflammatory changes.
Yes.
Is that correct?
Yes. I think by starting to repair the valve based on what we learned from our pioneer, now we know something that we have to put more emphasis, that is the rheumatic process does impair the diastolic function as well. I mean, the valve open not as good as normal. So we have to correct all of this restriction, fusion, shorten of the cord more. And also the pliability of the leaflet is a key. That we find a plan to peel it out and make the leaflet more mobile. In that way, we can improve the diastole as well as systole. And by the use of autologous pericardium and neocaudal reimplantation, we can recreate the damaged tissue like a leaflet and the cord, and that does improve the successful rate.
Regardless of the age of the patient, and in other words, if you have a patient who had this 40 years ago versus 10 years ago, I'm just curious because I've looked at these valves from my echo all my life, and I'm just thinking, you got this.
The question is really whether these inflammatory processes,
or maybe false hope of valve and valve down the line, failed prosthesis we can do. Does that influence your choice of prosthetic valve? I know if you had to put in a prosthetic valve, mechanical versus a tissue, what are your thoughts?
Yeah, this is another big concept about in the future, and then it does have some influence in terms of choice of the type of the prosthesis. That means we tend to use valve prosthesis in the more younger group now compared to the past. But whatever, to use it too young, the reaction is still there. That's why it's not so good. But the valve in valve, to me, I think trying to repair and then put in the valve prosthesis later, and then put in the valve in valve is really viable, and then can make the patient avoid from the need of the anticoagulation as a whole process. That is true.
I agree with that. I was still am a mechanical valve man. I preferred it for a long time. In fact, until about a decade ago, I was happy to place a mechanical valve in an 85-year-old, aortic valve in an 85-year-old. If it appears that you would last for another 10 years or so, that you could not repair.
Well, I mean, that's what's been so amazing for me to learn from both of you and watch that. I mean, because in this country, most people say, oh, we have to replace it, but you've done so. I want to compliment both of you because you've done so much to help so many patients around the world with rheumatic valve disease. I mean that sincerely, plus the fact that you're educating all of us. So thank you both for joining us. Thank you.